Good afternoon. Welcome to all of our audience. I'm Selena Lowe. I'm the Executive Director of the Australian Global Health Alliance, and I'm delighted to welcome you to our inaugural Global Health Congress and annual general meeting. The Alliance is the national peak body for global health organisations and institutions, strengthening the global health ecosystem in Australia. It was founded in 2016 to enhance the cross-sector collaboration and capacity of the global health sector in Australia. We have a great agenda for you today, and I'm delighted to begin by introducing Professor Lisa Jackson-Pulver, Deputy Vice Chancellor, Indigenous Strategy and Services at the University of Sydney, to open our Congress with an acknowledgement of country. Lisa is a visionary educator, placing a deep understanding of Indigenous issues and inclusion more generally at the heart of all she achieves. She's one of our leading commentators on education, health, research and Indigenous affairs, both in university environments and the Australian community in general. Over to you, Lisa, and thank you.
Thank you, Selena. Good afternoon, everybody, or good morning. I don't know where you all are, so no matter where you are, you're probably on a land that's always been loved, nurtured, has always been known. I'm standing or sitting today on the lands of the Gadigal people, the people of the Eora Nation, in a place that's today known as Sydney. This place has always been a place of life transitions, of knowledge exchange and of learning. 60,000 plus years Aboriginal people have been upon these lands. For 60,000 years, Aboriginal people have known something of this land, of this place, and today recognised as the world's oldest continuous culture. We do acknowledgement of country not so much as some sort of entertainment, but we do this as a practice, a cultural practice, a practice of respect. And that practice was highlighted back in 2007 and 2008 when Kevin Rudd, Prime Minister of Australia at the time, agreed that the first order of business of his incoming parliament was to say sorry to the stolen generations, the people who were forcibly removed from their homes and families and communities by the government of the days. And these stolen generations went on for a very, very long time. Many argue they're still going on today. Aboriginal people are a highly resilient bunch, and that I'm sure you know. But one of the things that Mr. Rudd asked for in the day before was for a proper welcome to country. And that occurred in the Parliament House of Australia. It was facilitated by a number of elders, including Aunty Matilda House. Aunty Matilda House, in her presentation, spoke at length about what is a welcome to country, and that welcome to countries are different across the land depending where you are and the purpose of them. But what she did say is that it was always a way for Aboriginal people to be able to transmit to their visitors, to the people that they are hosting upon their country, the various rules of the land, the structures of the land, things like where you can rest, where you can sleep, what you can eat, where you should drink, who you should talk to, how it is you need to belong. And as a part of that, that was afforded a protection upon the visitors of the land. And providing they stuck by the rules and the laws and the guidelines that were given them, they would be safe. They would be looked after as family, as kin, and as those of belong. Aunty Matilda House went on to share with us that today, her welcome to country, and those of the other elders who stood with her, was to welcome everybody to country on behalf of the Australian people, on behalf of the Parliament of Australia, on behalf of all of the people who came before her and all those who came after. Not only for the people who are witnessing this momentous event, but for all of those who came before, whether they'd been here for 60,000 years, whether they came here on boats, whether they came here on planes, or whether they're yet to come. If you sleep in this country overnight, if you call this joint home, then you have got rights, you have obligations, and you have responsibilities. And part of those responsibilities are to always pay respects to the place that you're on. So it gives me great pleasure and a great honour to be able to pay respects to all of the countries that you're upon today, no matter where you're listening to this, and to remind you that you're on Aboriginal land. This has always been a place of learning and knowledge exchange, and today will be no different. I pay respects to elders past, present and future, and I look forward to hearing more about what we're sharing today. So thank you.
Thank you so much, Lisa, for that beautiful acknowledgement. So our agenda for today is as follows. We're first going to have a conversation. Absolutely delighted to have the Right Honourable Helen Clark with us today. Helen, thank you so much for calling in from New Zealand. After which we will have a chair's address by Professor Brendan Crabb, and then a panel led by Professor Nancy Baxter, and a special screening of a global health film before we end the Congress. I would love to start by introducing Helen. She doesn't need any introduction, but I'm going to do it anyway. So Helen, as you know, is a respected global leader on sustainable development, gender equality, international cooperation. She has led many firsts in our world, not only in global health, but she served 3 successive terms as Prime Minister of New Zealand between 1999 and 2008. While in government, she led policy debate on a wide range of economic, social, environmental, cultural issues, which included sustainability and climate change. She was the United Nations Development Programme UNDP administrator for 2 terms and was the first woman to lead the organisation. Also the chair of the United Nations Development Group. From my perspective, I've had the pleasure and the privilege to work with Helen over the years because she's led and chaired multiple Lancet commissions and, most importantly, very recently co-chaired the Independent Panel for Pandemic Preparedness and Response. In 2019, she became the patron of the Helen Clark Foundation and continues to be an active member of many global organisations. Helen is a true friend and advocate of global health in all of her actions, and we and I are simply so delighted and honoured, Helen, to have you in conversation with us today. Thanks. Hi, Helen.
Can I just say, listening to Lisa's acknowledgement of country, how struck I was by the similarity with the concept in New Zealand of manaakitanga, which is welcoming, showing respect for, very strong, binds, I think, in bonds in the way that people think about these things. So kia ora, Lisa, and thank you for those words.
Thank you. I'm co-moderating with 3 incredible younger leads in global health, Jacqueline Bredhar, Todd Fernando, and Natalie Yap, who I'll introduce to you all in due course. But I'd really like to start a conversation, Helen, by asking a few general questions of you today. So I know you're calling in from New Zealand, where you've been for the course of the pandemic, but you've really continued to be extremely, if not even more active across all global health issues during this time. Apart from your work co-chairing the Independent Panel, you've also led conversations and commentaries on humanitarian crisis globally, which we've had the interest to follow, and continuing your commitment to planetary health and climate action. I'd simply like to start our conversation with the basic question of what, in your opinion, makes a good leader? What kind of qualities have you seen in emerging leaders in global health overall? And how do you think this manifests in your witnessing during the pandemic? Over to you.
Let's start with the generic attributes that make a good leader. First thing, empathy. If you don't like people and you don't have empathy for people, don't even bother about leadership, because leadership, whatever the field, always involves being a leader of people. So if you don't care about people, if you can't be bothered with people, you shouldn't be in a leadership role. Secondly, leaders need to be able to articulate a vision, and also important, a strategy and a plan to get there, because a vision without those things is not going to deliver very much. Thirdly, you have to be able to communicate that vision, strategy, and plan. And fourthly, I think it's really important to base it on the best possible advice that you can get, scientific, whatever. Now, those characteristics have been especially important during pandemics, and just to reduce it to its simplest, they're all the difference between Jacinda Ardern and Donald Trump, right? One shows all those characteristics, the other none. One gets a better outcome than most on dealing with this horrific experience, the other an abysmal one. So then when we come to the pandemic itself, I want to give a shout out to all the public health leaders who rose to the occasion. And there's so many across continents, regions, countries, globally. Here in New Zealand, the Director General of Health, Ashley Bloomfield, someone whose name, maybe a fraction of a percent of people would have known before the pandemic, became a household name as a trusted, respected figure. I have to say, I looked at Dr. Fauci in the US. Could anyone have had a more difficult job? He had to stare down the lens of the camera, ignoring the inanities of the president, and communicate the best advice that he could. I've also seen the work that Brendan Crabb, Bill Botel, so many people in the Australian context have done. People have really stepped up and put themselves out there to articulate a vision for how a pandemic should be managed. So Tom Frieden, the former CDC head in the United States, is another who's just kept at it with very, very useful messaging on social media. So a big shout out to all those trusted voices among the epidemiologists, the vaccinologists, the immunologists, the virologists, the biomedical scientists generally, the One Health people. I think it's been incredible. People have really risen to the occasion. And then when it comes to particular community leadership, so many communities, leaders at all levels have stepped up to make sure that messaging gets to their particular community. And as we know, mainstream messaging does not get to the furthest corners of any land, whether you're a low income or high income country. It's not a one size fits all. So those to all have gone the extra mile. Thank you.
Very much, Helen. And of course, in your usual humble way, you've there is one more leader, which is yourself, in terms of all of the work you do across all sectors, as I mentioned before. But it's a really good segue into my second question for you, which is regarding the pandemic. I mean, at the outset of the pandemic, world leaders vowed in all countries to spare no effort to ensure an equitable response to the pandemic. Yet almost 2 years in now, despite some significant efforts such as COVAX, the ACT Accelerator and numerous bilateral aid packages, the health inequities between high and low middle income countries are never more stark and growing by the day, and really revealed how inadequate so many healthcare systems are around the world to cope with multiple health crises. In some ways, we as the global health community really feel we're clearly not doing enough. And are you able to share any advice you have specifically for Australia in this region? For example, we know that our government has prioritised a bilateral response to support regional efforts, but is there more we should be doing to improve regional health outcomes, for example, multilaterally? And linked to this, if you can, share any thoughts on the future of multilateral initiatives for global health.
Well, the response to the pandemic really hasn't shown the multilateral system and countries' commitment to it at its best at all. And that's a cause for sober reflection, because if you can't bring everyone together around a good response to something that threatens the health of each one of us, what can you bring us around? We see the struggles with climate change, but COVID was in our face, a threat to the health of every citizen in the world, and still we can't get it right. I think when we started our work as an independent panel, we set out to truth tell, not blame cast, because you can learn from the truth as lessons learned, and we based our recommendations on what we learned. What we learned was that the WHO was very underpowered for the job that was expected of it. It has a budget about the size of a large New York hospital, I understand, which is in the global scheme of things not big. And the problem was, when WHO did shout on the 30th of January, no one took too much notice. I think for Australia and New Zealand, we snapped fairly quickly on closing borders to travel from China, and then progressively closed our borders to everybody. And that's pretty much still the case in New Zealand today. I think there's a bit more opening up in Australia now. But apart from that, we didn't really get the message in February either, and nor did most of the world. It wasn't until the pandemic broke out in enforce in March in Italy, that people started to think, my goodness, this could be us. And then everyone went into a panic, and has more or less been in a panic since. So, of course, what has come through is it's not only a pandemic of a previously unknown coronavirus, it's also a pandemic of inequalities, which strikes those who have some marginalisation for whatever reason the hardest, whether in our own communities, it's Indigenous people, whether it's people who use drugs, whether it's the homeless, whether it's the poorest in general, whether it's those with the gross health inequities, often relating to the inability to access proper nutrition, those who are suffering from multidimensional poverty. It's been tough on all those marginalised in our own societies. And then with the global perspective, the marginalisation of, for example, Africa is chronic. Not only Africa, there are other least developed and low-income countries who've had and continue to have a really tough time of it. But, Africa still struggles to get the vaccination rate above 6%, and I may be being generous in saying that. And fake news, by the way, isn't just something that comes through, Facebook in Australia, New Zealand, the US. Fake news is damaging the response across regions of the world as well. So the conversation has, for the most part, focused in on the vaccine inequity, and our panel did have quite a lot to say about that. We said that high-income countries like Australia, New Zealand, UK, US, basically OECD countries, had ordered twice as many doses as they needed to dose their population. And they needed to be getting those doses out quickly to try to at least help the countries with less access to vaccinate their most vulnerable and their frontline workers. And we said 1 billion doses could have been put out by September. Well, of course, they weren't. You'd be lucky to see redistribution of doses get to 200 million. And there have been ongoing calls since, get it out there. Sometimes by the time it gets out there, what is delivered is so close to expiry date it can't be used. And the Independent in the UK has just run a major article about how the UK destroyed 600,000 doses of AstraZeneca, which got to expiry date and then never got out there. When we talk about multilateral responses, we need quick channels for countries to say, I've got spares, where should it go? And maybe, cut out the middleman of putting it through COVAX, but at least know where the gaps are so that everybody doesn't send their spare doses to the particular donor favourite at the time. We've got to have this better coordinated. So the vaccine redistribution has been woeful and far short of what should have happened. But of course, that was only the tip of the iceberg of resolving the vaccine issue. The vaccine manufacturing, apart from AstraZeneca getting it to Serum Institute in India, which can produce, and India can produce vaccines big time, but of course it had its own horrific wave of pandemic. And the response to that was say, we're going to vaccinate at home first, which you can understand, but COVAX had relied on supply coming from the Serum Institute. So that's made it worse. Pfizer and Moderna are getting very, very rich off these vaccines. They haven't been putting production out there. And yes, of course, we're now seeing news about maybe vaccine manufacturing in South Africa, Rwanda, Senegal, but it hasn't happened. We need vaccination capacity built up at scale in the global south, because we're going to need to keep producing these vaccines, right? It's not just a two-shot once off. Everybody's going to need these boosters. We're going to need to keep producing them for new age groups coming through. So this has been very troubling. And then my last point on this would be India and South Africa led an initiative at WTO to get a TRIPS waiver, intellectual property rights waiver, for all the goods, commodities associated with the pandemic, not only vaccines, but therapeutics as well. Well, you can imagine how fast that is going. The Biden administration came on board a number of months ago, but in Europe there's been significant resistance, and not only there, to negotiating that. My humble opinion is that a TRIPS waiver should be automatic when there's a pandemic. And I go back to the philosophy expressed by Jonas Salk when he was asked if he was a rich man as a result of inventing the Salk vaccine, which many of us had as children in my generation at school against polio. And he said, words to the effect, good grief, no, this was a gift to humanity. Well, sadly, the Pfizer and Moderna and other vaccines have been a gift to the shareholders, and that isn't right.
Thanks, Helen. It's interesting you mentioned Jonas Salk. He also was once quoted around the polio vaccine saying, we need to think about being good ancestors, which is pertinent not only to, vaccine equity and justice, but also planetary health. So just a very quick question before I hand over to my co-chairs. One of the recurring themes our Alliance members working in humanitarian crisis keep hearing, and that relates to countries such as Myanmar and Afghanistan, is the cascading effects of takeovers. Whether it be the Taliban in Afghanistan or the military junta in Myanmar, what we hear from the front lines is that one of the major impacts is the cessation of aid. The Afghanistan economy was heavily reliant on aid. 80% of the government budget was foreign aid and 40% of GDP was foreign aid. So how can governments around the world best support humanitarian aid flows when there are significant questions around the people in power?
Mm-hmm. Yeah, and it's challenging, right? But there are ways through, and we could add to the list of Afghanistan and Myanmar, Tigray region of Ethiopia, which is under an aid blockade in effect, and many others as well. But having some engagement with the issues around both these countries, first I would say that the multilateral system and the international NGOs which can operate become extremely important, and also the local NGOs, because ideally you should do things locally if you can, but whether they can operate will be an issue too. So for the multilateral system, you'll find in Afghanistan that the humanitarian agencies of the UN will be very busy there, UNICEF, UNHCR for refugees, IOM for displaced people, World Food Programme. UN Women has hung on in there, including with the international staff. UNFPA will still be there, right? And they do so much for displaced women with dignity kits and basic supplies. So I think that those organisations become extremely important. There are again international organisations there from the NGO sector, and then those who many deliver through, who are on the ground organisations. You can support Afghanistan without putting the money into the Taliban's coffers, where it might finance something that you don't really want financed. With Myanmar, similarly, there's also ways of going in through civil society there, particularly through the border areas. But look for ways that don't involve an acknowledgement of the Tatmadaw, which seized power in February, and look for organisations with integrity which can get the money out to people. So the fact that there's shocking people in power in the capital doesn't mean we should walk away from the people. Far from it. They need support more than ever.
Thanks so much, Helen. I'd like to now hand over to my three co-moderators who are, and I'll introduce them. If you could all come up to the screen, I'll introduce them together, and then we'll go through the question line before we open Q&A with Helen. So the first is Jacqueline Bredhauer, who's the President and Chair in 2021 of the Australian Medical Students Association Global Health. She's a medical student at Monash Uni. She's passionate about systems change for human and planetary health and has been involved as a student in research in mental health system reform, drug harm minimisation, NCDs, and climate action. Over to you. And then the next speaker is Todd Fernando. Todd Fernando is a descendant of the Kalari peoples of the Wiradjuri Nation and identifies as queer with pronouns he, him. Todd is the Victorian Commissioner of the LGBTIQ+ communities, the second person to fill this groundbreaking position. In this role, Todd works closely with Victorians' communities to provide crucial advice to the Victorian government. And Dr. Natalie Yap, who's a paediatric doctor and who has a strong experience in global health, gender equity and leadership. She's worked with a diverse range of health-related non-government NGOs and has represented Australia on behalf of the Medical Women's International Association at high-level UN events globally. So I would like to start by inviting Jacqueline to ask your conversation with Helen. And Helen, of course, as I said before, that you are welcome to ask us or the audience any questions too. Jacqueline, over to you.
Thanks, Selena. It's lovely to see you, Helen. It's a great privilege to be able to hear from you today and talk to you. So I'm just going to ask a question based on my experience as a student and working with lots of other young people and medical students in Australia and across the world. So what I've found is that the unique perspective students bring at the moment is not just due to our youth, it's actually due to entering the working world at a time when global systems are fragile. So to coming of age at a time when we can't actually be sure about what our future will hold, faced with the climate crisis, this current pandemic, rising geopolitical tensions, and ever worsening inequality. So Helen, my question for you is, how can we meaningfully elevate the voices and perspectives of marginalised social groups, like young people, who have been traditionally excluded from mainstream academic and political discussions? Thanks.
I think, start with the advocacy that there should be no decisions about us and our future without us, and really force your way in. My experience is that no one rolls out a red carpet, really. You're going to have to knock the door down and roll out the carpet yourself. I often make that point about women trying to get into politics. But it's the same with your youth voices trying to be heard, right? You've just got to say, excuse me, I'm here. And I've got very strong views about this. My group's got very strong views about it. I have to be included. I think we went through a number of years where young people were a bit quiet, actually, compared with my generation of issues. I cut my teeth as a student on the anti-apartheid movement, the nuclear disarmament movement, the movement against the Vietnam War, movement against foreign bases in New Zealand. We were busy and we were pretty noisy, and that was kind of typical of the late 60s, early 70s generation. But then things went a bit quiet, and I think perhaps the climate change issue has thrust young people back more into a leadership position, but it has to go beyond Friday school strikes and so on. It's got to go into how do we actually access where the levers of power, the decisions are actually made. How do we force ourselves into the engagement and discussion and policy making and actually being heard. So that's my advice. Force your way in. Don't wait to be asked, because they won't ask. Just force your way in.
That's fantastic advice. Thank you so much, Helen.
Thanks so much, both of you. Todd, I'll hand over to you now.
Thank you. Hi, Helen. It's a pleasure to meet you. This week in Australia is Trans Awareness Week. And over the past few years, we've witnessed some real movements to protect and offer culturally sensitive healthcare for our trans and gender diverse population. However, while trans and gender diverse people might not be pathologized at the levels we've previously seen, they are still experiencing high rates of discrimination within healthcare settings more broadly. As a result, we're still falling far short of offering gender affirmative services that are person-centered and respectful. All too often, trans issues remain, if not a political football, then fodder for the worst parts of the daily press. So my question is, how might we turn this around and activate health leadership both locally and on the world stage to promote the fundamental need for global health equity? Which is a PhD question in 1,000 ways, but yeah.
No, so thank you. And I think the Awareness Week is great because awareness on the trans issues lags quite badly behind awareness of a number of other groupings within the LGBTQI plus communities. So awareness is raising is good. I think what we've learned from good public health responses is, and I'll go back to what I said earlier, there's never a one size fits all. If the approach isn't in a way led by and responsive to particular communities, it won't work. And if we draw on the lessons of the HIV response, for example, and I was a Minister of Health at a relatively early stage of that in New Zealand, and I think similar experience in Australia, we could never have got on top of that without working with the key populations. And the key populations were in LGBTQI+, they were among sex workers, and they were among people who inject drugs. If we just sat on a podium as the minister, the public health officials, one size fits all, would never have worked. And the leaders came out of those communities to ensure a successful response, and were actually part of a huge attitudinal and cultural shift in our country towards acceptance of diversity and acceptance of the choices that people make. Say, for example, with respect to use of drugs, some of which are illegal and treated completely different from others, but that's a longer story. And the change in attitude was so profound that the leader of the Prostitutes Collective, Catherine Healy, who did an amazing job, was in recent years honoured in the New Zealand Honours List with the highest honour. So this would have been unthinkable when we started down this road. So it's a long road, and I think I appreciate that the trans awareness has started quite a way back from where others have already got awareness to, but just keep at it and demand people-centered responses, which work with people as they are, who they are, where they are, and make it relevant and keep it real.
No, and I think that's important, considering Reagan during that reign, and where we are now, particularly on the HIV front, is telling of how an administration really can influence community. Thanks.
Yeah.
Thank you so much, Todd. Nat, over to you.
Thank you so much, Helen, for such an enlightening conversation about the opportunities and challenges in global health and leadership, especially in light of COVID. And thank you to the Alliance for also including some young people in the conversation. So my question is on a similar note from Jacqueline's about elevating young people's voices. As a lot of you are aware, adolescents and young people are often overlooked in health policy and programming, yet more than 3,000 adolescents die globally every day from largely preventable causes. How might we ensure that adolescents and young health and development remains at the centre of national, regional and global health agendas? I know, not a small feat. And how can we keep our governments accountable for creating youth-responsive policies and programs across all sectors? Thank you.
Thank you. And I'll put on my Partnership for Maternal, Newborn and Child Health hat here because it's an area of advocacy that PMNCH is very active in and has a very active adolescent and youth constituency. And PMNCH has been part of spearheading the call to action on adolescent health, which is calling for stronger political commitment and funding for adolescent health. and also has been, part of getting out the global consensus statement on meaningful adolescent and youth engagement. So again, it goes back to that principle of nothing about us without us. We don't want decisions handed down being told what's good for us. We want to have, as adolescents and youth, a say in these things. I think there is a wider acknowledgement now that adolescent health has been a greatly overlooked area of health. We tend to obviously focus a lot on the newborn, the infant, the under fives, even primary school age children. But you come to those teen years where there are a lot of issues, but they haven't had the focus. There is hope, I understand, of getting to an adolescent global youth summit of some kind in 2023. But the basic call will be for that extra political commitment, the funding, the specific strategies, the multi-sectoral approaches, because it's not just health, there's a number of other things that need to come together. So if you don't know of it, go to the PMNCH website. They are very active, and Susan Sawyer, I think, is on line. There's a major adolescent health and wellbeing event coming up, and I think it's starting to get the attention that it needs. But of course, behind at this stage the awareness and attention of a lot of other demographics.
Wonderful.
Thank
you so much.
Thank you so much, all of you. So we've got about 9 minutes left with Helen before we release you. But we've got a couple of questions, and as I said, you're welcome to ask also. I'll start with the first question, which is from, I think it's from Professor Ian Anderson, who is actually one of the founders of the Alliance and will be rejoining us on the advisory board. My view is that the Global North is often unaware of its ethical position in relation to its somewhat colonial attempts to leverage change across the globe. And this requires probably some unpacking. I don't know if you have any comments to that, Helen, in regards to the perhaps blindness of the Global North and in regards to its ethical position. As you probably know, there's there's been quite a lot of global debate on decolonisation of global health, which we will unpack a little bit more in our next session too. Don't know if you have any comments for that.
Yes, yes, and I think it's an evolution of a debate which began, probably more than 15 or so years ago, which related to the issue of aid more generally, development assistance more generally. And there were various conferences, Paris, Accra, OECD-led, on, quote, aid effectiveness. And the OECD donors did sign up to a set of principles which included, country leadership and definition of, what the needs were and where they would like to invite support. But I haven't been at UNDP now for 4.5 years, but it was such a battle to get away from tied and tagged aid and aid that often, ended up with, more in the pockets of consultants from the source country than on the ground. So it does require a major shift in attitude, and I think that the decolonisation of global health, decolonisation of development support, it's really important to keep pursuing this, because otherwise you have the projection of what others think needs are, rather than being able to define them yourself. Look, when there's a redesign, which I hope will happen around a response to pandemics, one of the things that's screaming for redesign is the platform that was cobbled together, the Action on COVID Tools Accelerator and COVAX, which my understanding is didn't have a lot of engagement from low income and low middle income countries. It was more or less handed down. It hasn't been very successful. It's been a market model approach, hasn't really got the goods out there. And we recommended a redesign of that on a global public goods model, and also implicit in that is governance, which gives a fair say and voice to those who are most likely to need the solidarity. So it needs a lot of unpicking, and it'll take many forms in the debates, but it is an important debate.
Thanks so much, Helen. There is one other question from Lavanya, who's I know is based at UNU, International Institute for Global Health in Malaysia. If you have time to answer this one too, what are, if any, the policy alternatives and innovative approaches to counter the impact of patents, trips and disproportionate power holds of those who financially benefit on the global inequities of access? How can the Global South drive the pursuit for fairer access to vaccines and therapeutics beyond COVID-19? So going on from what you were just saying.
Yeah. Well, it would help to have a complete redesign of the platform so that you have something pre-negotiated when you're coming into a pandemic threat, where it's accepted that there will be a global distribution and allocation system. I mean, it might sound idealistic, but that's what we need. Instead, we were left with a lolly scramble, where those who could pay and order up front ended up getting the goods first, and those who were dependent on solidarity are still waiting for the vast majority of their populations. So what I would say to countries is look at all the tools that you have with respect to compulsory licensing. Some countries have been adept at using compulsory licensing. The mRNA people tried to make it all sound very complicated, but the reality is that if they don't release intellectual property one way or another, countries will endeavour to access through compulsory licensing, which may be faced with the threat of that. The big pharma might talk turkey more readily. But the significant answer would be, as I said, to have agreed an automatic TRIPS waiver when the WHO declares a pandemic. Now, bear in mind that at the moment, the WHO doesn't, quote, declare a pandemic. That's not in its dictionary. Its highest level of warning is a public health emergency of international concern. And one of the things to consider is whether you need a level above that, where you just say, stop, everyone, this is so significant, so threatening, all bets are off with intellectual property, it is going to be a waiver, and we have to get the stuff out there. So that's what's to play for, I think, in the future.
Thanks so much, Helen. So I know there's only a few more minutes. I'm actually going to, before I go to like any new questions, I was going to ask you if you've got anything to ask us. There are people on the panel and audience ready to assist in answering, so.
Well, we sit in New Zealand and watch the pandemic response in Australia, and I guess we're interested. I know Brendan is one who comments a huge amount on this. Where do you see the pandemic going in Australia now? You have states which have kept it at bay, including Western Australia, but you've got others where you've got significant numbers of cases still. Where is it going?
Yeah, thanks. Brendan, do you want to pop on and answer that in exactly 2 minutes?
I can have a go. Thanks, Helen. It's of course a very state-based response in Australia. We've got a whole bunch of them that are still in COVID zero, not maskless, going about school and work and theatre and movies and everything. And of course, 2 states and 1 territory that have struggled a lot this year, and Victoria, my home state, that struggled a lot last year as well. I think, in short, we're entering a honeymoon period where recent high vax, both of which are important, the recentness of it and the fact that we've got high vax in the over 12 population, and still a very active test and trace system. Now, we haven't dropped test and trace and haven't dropped public health measures completely, even though they're a bit patchy at the moment. we go through this, this significant decline, I think, just like some of the good European performers on vaccine rollout, Portugal, Denmark, and so on did. And then it will depend on whether we make the same mistakes, and they made some mistakes that were they didn't know about. Of course, we have the benefit of being able to observe what happened. The first of them is you can't just drop. There's no open day. There's no freedom day.
Yeah.
There really isn't at any level of vax yet that we know of. There's no freedom day. So maintaining, in my view, an evolving smart test and trace system and maintaining airborne mitigations. In fact, it's been the big blind spot of the world, growing airborne mitigations. I saw something the other day about Ireland. I don't know how true this is, but Ireland's got something like 120,000 buildings. 50% of their infections happened in 400 of them, just 400 buildings. And that rings very true. That's the nature of this virus. It's an airborne virus. Actually gives you the clue to why we get all the super spreading and how to deal with it. So there's no freedom day, keeping something in place, and I think then looking hard to a much better 12 months from now. This is rich countries now. In rich countries, we will have 3-dose vaccines, I think, as standard. There won't be a booster. My crystal balling is it'll be standard, and we'll boost on top of that probably, depending on your antibody levels. We'll have drugs like Merck and Pfizer have announced. We'll have, I hope, a much more sensible and improved mask wearing strategy, much less vexed than it is now. We'll have kids 6 months and up vaccinated with a bit of luck. And if the virus doesn't change radically, and that's a big if, of course, we're on our 4th variant of concern. So I think the prospect is good. And the reason I say that is I want it to motivate our communities to keep going, and not, in this country at least, I feel our attitude is we're tired of it. We're really tired of it. It's an understandable attitude. We're tired of it. We want to move on. We want to open up in every way. And I think it's that we're entering quite a risky period, frankly, in this honeymoon period, to going to what the Netherlands is going through now, lockdown for unvaccinated people. The big spikes we're seeing in Singapore and other places, we really admire admired their response. So a tricky period, but pales into insignificance compared to our neighbours, particularly Papua New Guinea. And so we've obviously got to keep that in mind. But from an Australian perspective, we're in a very fortunate position to be able to learn lessons from elsewhere, and I just hope we do.
Thank you so much, Brendan. So Helen, indeed a pleasure and an honour. Thank you so much for giving us your time. To Todd, Nat and Jacqueline, thank you indeed. Really fantastic to have you helping with the moderation of this session. And I don't know how we do it on Zoom, but the Zoom clap is in order. Please join me in thanking Helen, Todd, Jacqueline and Nat for this session, and go peacefully to what you have on next.
Thanks, Selena. Bye, everyone.
Bye. I have great pleasure next to invite back Brendan in his role as chair of the Alliance to give his chair's address of the Global Health Alliance, Australian Global Health Alliance, before we move to our next panel. As most of you know, Brendan is the chair of the Alliance, but also chair of the Pacific Friends of Global Health, the secretariat of which is housed with us here at the Alliance, and he is CEO and director of the Burnett Institute. He's a fellow of the Australian Academy of Science and a fellow of the Australian Academy of Health and Medical Sciences and of the Australian Society for Microbiology. And Brendan has been commentating all through the pandemic, but handing over to you now for your chair's address 2021. Thanks.
Thanks so much, Selena. And I know if I only had 1 minute, what I would say is that the Alliance had a great year because it found you. Basically, you don't see us behind closed doors, but we're just so delighted you chose to come and work with us, Selena, and already made such an impact, and it gives me confidence about our future more than anything else. So thanks, and thanks for doing today under such trying circumstances. Look, and I just didn't get a chance to thank Helen then. Thank you, Helen, and thank you, Lisa, for your welcome to us today. Those, really rich and important and challenging words, frankly, for a non-Indigenous Australian who really struggles to find the right tone, not just in a specific meeting, but I mean for me personally, for my organisation, for my advocacy for our country that is so desperately in need, more than anything else, of charting an appropriate recognition, partnership, friendship, celebration of what I would like to think of as our 60,000 year history. And it troubles me deeply that we're so far from that. And yet and I now know you a little through our work in Osage, it's just, I feel a step change is upon us. So thanks so much for that. And we'll keep working very hard from a Global Health Alliance perspective to meet that challenge. So thank you. Well, for those who don't know, the Alliance begun some 5 or 6 years ago in 2016, and there are a number of founders. Ian Anderson was mentioned. I'll mention Ian again in a moment. Helen Evans, I'd like to particularly acknowledge, but a bunch of us really came together, and I guess for my description was, we were all passionate global health people, but it was like the perfect global health omelette was still in its component pieces. It still is in its component pieces, chopped up on the board or on different boards in nice, neat, beautifully fragrant piles, but nowhere near yet to making that really impactful mixture. And my background is in malaria. I'm a malaria scientist, and yet my own world of malaria is so collegiate and good, but so disconnected. Those doing science are so separated from those doing advocacy, who are so separated from those implementing in the field, who are so separated from those who actually get sick from malaria. These are really different worlds. They're funded separately, they're measured separately, and maybe it's not terribly surprising that in that one example of a complex public health problem, the global health problem, sort of in 100 years of effort, I haven't got that far. We have made progress, and I don't mean to underplay the progress, but malaria is nowhere near solved, as just one example. And so that was a big motivator for this group of people coming together to say, can we provide a platform, at least, not just a peak body, but a platform for us to firstly have a conversation. And that was the most important, and still is the most important element, to literally get to know each other from these different parts of the global health omelette, and then actually do some things and evolve into actually doing something that's useful for this multidisciplinary, interconnected global health group. So we have been going for that period of time. We are committed, as I've just said to Lisa, to advancing the health of First Nations people, to this new field of planetary health, and contributing to future generations of global health leaders in the region. And I guess of very much maturing from what would I say, the more traditional, I'm trying to find the polite words, but the traditional, very top-down, rich country-driven I'm trying to avoid using the word colonial, but I know that we still naturally default to that a lot, and we're very serious. I see Sayers on the we're going to hear from today, very serious about change, but under no illusion about how fundamentally difficult it's going to be to move to much more community-centric approach to all we do, as Helen touched on before. The communities that that are low and middle income, the communities that are marginalised and vulnerable, how can they actually lead us? How can we work alongside them rather than in this top-down way? They're the sorts of things that well, very much not sorts of things. That's essentially what the Alliance is motivated to try and achieve. So I'd just like to say a couple of words about the last year, of course, and the future one. It's already apparent that, in the words that have, in Helen's talk and in Selena's introduction, we were all aware that inequities were deep and entrenched. But I think, at least I can speak for me, I've been a bit shocked at just how much we've failed as a rich world to address inequities, even when it's so blatantly in our self-interest to do it. Addressing inequities is always in the world's self-interest, but COVID showed us just how much it was, and we still failed. We failed even worse than I think could have been predicted, at least worse than I predicted. So that's the challenge. It's shown the degree to which we have a challenge. I think the opportunity, though, going forward is that I don't know what the right quantum would be, but the focus on issues that are important to us, the health issues and the inequity, is 1,000 times brighter than it was pre-pandemic, pre-December 2019. Everybody knows, literally everybody in the world knows something about these issues now. That's our opportunity to take advantage of that knowledge. You'll never speak to another politician again who doesn't know about global health issue, who doesn't know about how they disproportionately affect those at the bottom, and how that effect paradoxically smashes everybody. There's no way of quarantining it somewhere, as I think we like to think in malaria and in HIV and in TB has happened. It's going to be much harder to quarantine this away with new variants, with the fundamental effect on trade and security and economies that COVID's is likely to have for quite a long time. So I think there's a tremendous opportunity there now, and we're going to need it with pandemic ongoing, with more pandemics very likely. The frequency of them is increasing significantly, and of course with the much bigger challenge, interrelated challenge of environmental and climate driven change that COP26 has just shone such a big light on. So that's some thoughts from me on the year that's gone and the opportunity that's there. And just from a practical point of view, we're really pleased to welcome some new sponsors and some elevated sponsors. The so-called bronze sponsors that we have, the MMV, Medicines for Malaria Venture Group, that because of my history I'm so familiar with, we welcome them and Leanne Joyce specifically to our advisory board. The University of Sydney, thank you to you, and maybe many more universities, perhaps through you, get involved in the Alliance. And as members, Vic Health, and Sandra, I know you're on today. Thank you so much for supporting the Alliance. And to the Royal Children's Hospital, one of Australia's really great contributors to the health of our community and to the region. Thank you for joining. I mentioned Ian. Thanks. Welcome back, Ian Anderson, rejoining the Alliance board. Ian was, as I said earlier, instrumental to foundation of the Alliance and as a leader in the tertiary sector and, of course, in Indigenous affairs. He's currently Deputy Vice-Chancellor at ANU, and we're really delighted to have you back. So welcome, Ian. And thank you to all of those sponsors who are still existing and members, and part of the onus on all of us who are sponsors and members is to keep recruiting, try to find new organisations and individuals to join us. I mentioned also the wonderful news that Dr. Selena Lowe has joined us as our Executive Director, and of course I'll hand over to Selena in a moment. We're just delighted about that. I took over as the Alliance Chair not that long ago, and I'd like to acknowledge Jane Den Hollander, Professor Jane Den Hollander, who I succeeded, and John Brumby, who was our inaugural Alliance Chair. You know, both John and Jane gave this place a future. You know, effectively with this core group of Helen and Jane Fisher and a few others. You know, they have set this place up to be able to do some things, you know, in the decades to come. It was not clear at all we had that future. So super acknowledge John and Jane. I'm very happy to take up the chair. I'm still not sure that I'm the right person for it. I'm definitely passionate about the Alliance. Its goals fits my own personal goals. You know, whether now that we have someone so competent in the Executive Director role, whether, you know, we need to evolve to a Helen Clark type figure. But I'm absolutely delighted to take it up and to use whatever profile through the pandemic and through my other peak body roles to influence governments, influence policymakers, and you know, do what we can to put the omelette together, which is really the challenge that we have, so that we can be much more than the sum of our parts. We've achieved a lot this year. You know, it's a very small secretariat still, and we'd like to grow that. But that group can be incredibly proud of what it achieved. We got together with the End COVID for All campaign in a very meaningful way. End COVID for All is led by Micah Australia, and I think part of the beauty of the kind of culture of us as the Global Health Alliance, we don't care whether people are in the Alliance or not really. We're part of an ecosystem that we're really happy to join with, partner with, go from behind, partner beside or lead, whatever our role, the useful role for us. And in End COVID for All, it's just been a wonderful alignment with all sorts of organisations. And if you haven't read it yet, the Shot of Hope report that came out recently outlining Australia's role, or the role that Australia needs to play from our perspective in helping vaccinate the world. Please get hold of it and arm yourself with that. We've also, you know, found new opportunities for collaboration with our alliance, provided the platform. I mentioned that we're basically a platform organisation, and we've used that to share our knowledge and knowledge generally that all of our stakeholders have. And, you know, some examples include the Global Health Seminar Series with the University of Melbourne, and hosting the launch, which is absolutely fantastic, very recently, of the new occasional paper on HIV and health security from AFAO, the Australian Federation of AIDS Organisations. We're to hear in a moment, I think, but since 2019, we continued to host the Secretariat of the Australian network of the, I think now 56 WHO collaborating centres. And we also host the Secretariat of Pacific Friends, as Selena said, that I chair Pacific Friends of Global Health, which is really advocating for funding for Gavi, the Global Fund to Fight AIDS, TB, and Malaria. So Gavi, the Vaccine Alliance, the Global Fund to Fight AIDS, TB, and Malaria, and UNITAID. Those three multilateral groups seek support from our government, and it's us that try to do that for them. And just in general, we work to raise political and public awareness of global health issues facing the Indo-Pacific. And I listened very closely to Helen's comments there around COVAX and the ACT Accelerator and the redesign there, which we're going to have to think hard about at the Pacific Friends. So both the Pacific Friends and the WHO collaborating centres are entities that were initiated by the Alliance, and they operate under the auspice of the Alliance. And that was one of the big reasons why I stepped in as chair of the Alliance to make that dual job, at least with Pacific Friends, relatively easy. And this year, in partnership with APLMA, another malaria group, the Asia Pacific Leaders Malaria Alliance, we established a malaria network in Australia, again cross-sectorial, back to that theme of the different components coming together, and now exploring how we could build on this. But it was just a fabulous process. So, and a sort of an indicator of the sorts of things for the Alliance. It's just it's such a sweet spot to address. So look, thanks to the board, the extraordinary board of the Alliance, and the exec committee who do so much, so many hard yards. Everyone contributes voluntarily to their time and expertise, and to our secretariat, to Selena, to the Deputy Director, Abby Minter, who's been just wonderful, and to Piali. What a team. Those three do 6 people's work easily, and make it very enjoyable too. It's a really enjoyable organisation to be a part of. And to the sponsors and the members, there'd certainly be no alliance, so thank you to you all as well. And with that, I will hand back to Selena am I handing back to Selena or to Abby? Selena might have gone, that's why I'm not sure. But thanks very much. And Abby, I think I will hand over to you as Deputy to take us forward.
Brilliant. Thank you so much for that, Brendan. Our next conversation will engage us on the future of global health knowledge, and I'm delighted to hand over to Professor Nancy Baxter to lead this session. Professor Baxter is a clinical epidemiologist, surgeon, and health services researcher, and is currently the head of the Melbourne School of Population and Global Health. Nancy moved from Toronto to Melbourne in February 2020 for an adventure, and COVID did not disappoint. As a researcher, Nancy has been in the public eye for a number of publications, particularly in the area of cancer screening and quality of surgical care. As a public health leader, Professor Baxter has been a leading voice in the Australian media during the pandemic, helping Australians understand the pandemic and how their individual and collective actions can have real impact on the health of their families and communities. Over to you, Nancy.
Well, thank you very much, Abby, and really looking forward to our conversation today, which I think is going to be enlightening, engaging, and hopefully move us forward. So we have 4 fantastic panelists, Dr. Shaya Abimbola, Dr. Lisa Jackson-Pulver, Dr. Sandra DeMaio, and Dr. Michelle Reme. And we're going to be talking today about globalizing health, globalizing knowledge, and globalizing leadership everywhere. And what we're going to do to start is I'll introduce a speaker, and then we'll have them say a few words, and then we're going to have a conversation. So let's start with Dr. Shaya Mbebola. A health systems researcher from Nigeria. He is currently a senior lecturer at the School of Public Health, University of Sydney in Australia, where he teaches global health and uses realist methods and theories from institutional economics to study health systems governance. Dr. Abimbola is also the editor-in-chief of BMJ Global Health and the current Prince Claus Chair in Equity and Development at Utrecht University, where he's working on justice in global health. Shay, how about a few words?
Okay, so thank you very much for having me, and thanks to the organizers. I thought I would just talk a bit about the idea of knowledge and how power weaves into everything we do with knowledge, and how that is such a major issue in global health. There's a lot of conversation around decolonizing global health. And to my mind, nothing is as consequential to decolonize as how we think about knowledge. First, and I think most importantly, how we reckon with the knowledge that is held by, produced by, and needed by the people who are the typical targets of global health interventions or global health programming. So, I mean, people who, for some reason, are disadvantaged, and I use the word disadvantaged as a verb. So it could be people in low and middle income countries, could be people in communities, even in high income countries. Our knowledge infrastructure and knowledge ecosystem is, by its very design, optimized to work for people and by people who are privileged and who are sort of in high income countries, etc. And if we want to take decolonization seriously, we have to start to reimagine what a knowledge ecosystem that is designed for people in low and middle income countries, by them, and to address their needs, what it looks like. And I think it is a major work of the imagination that needs to be done. Helen Clark mentioned earlier that leadership is having a vision. And I've thought long and hard about what the alternative looks like. So when we say we want to decolonize knowledge production in global health, what does that look like as an alternative? And I think that it is a much more difficult task than it sounds when it's said. And it's a task that requires that people are courageous and bold and willing to take the risks to imagine what a different world is, and to be willing to work and chart a path towards that alternative vision. And I think it's the kind of work that we need to do as a community and as a group. And I'm really keen to talk about that, hopefully, as we proceed in this session.
This is a very, very exciting way to start. Our next speaker is Dr. Michelle Reme, who is the Deputy Director at the United Nations University International Institute for Global Health, where she leads the Gender and Health Hub. She is a health economist with over 15 years of experience as a researcher and policy advisor in global health, having worked in academia, the UN system, donor development cooperation, and private consulting. Prior to joining the UNU, she served as assistant professor in health economics at the London School of Hygiene and Tropical Medicine. She conducts research and provides policy advice on topics related to the economics and financing of health programs, health systems, and gender-responsive health interventions. Michelle.
Thank you so much, Nancy, and it's great to be here. Thank you to the organizers for inviting me to represent UNU, International Institute for Global Health. I had a couple of things to say. I'm trying to see how I could succinctly start off with some key points. I think what I was thinking of starting off is a little bit following on what Shaya said as well, is sort of what does success look like in global health knowledge going forward and in the future. And for me, there were a couple of things that would come up, and I'll just highlight a few, and I'm sure we'll continue the conversation. I think one is that we need interdisciplinary knowledge, and I know the global health field defines itself almost as multidisciplinary and interdisciplinary, but it does remain firmly driven by biomedical framework. And this creates real constraints for the possibilities for innovation and for deeper understanding that informs action. And often other disciplines find themselves trying to fit within this core framework at the expense, I think, of complexities and of nuances in those frameworks, and at the risk of being instrumentalized. A lot of the work we do at UNU, or the work I'm leading at least, is around gender and health. And we've seen that in that area where there's been a tendency to overprivilege the biomedical and the technical in an area that's fundamentally multi-sectoral, and it's meant we've ended with sort of box-ticking approaches to gender equality rather than approaches that really have an ability to transform gender power relations. And so this really is a constraint for our potential to promote gender equality. The other element of knowledge was around pluralism, and I think it relates very closely to this point, is the hierarchies in evidence and knowledge, and what is considered rigorous in global health is largely quantitative, experimental evidence, for all research questions in many ways, and it disregards other types of knowledge. And I just wanted to pick up on, related to what Shay was saying as well, I think, is a particular gap is how we value practice-based knowledge, and that's both of communities and people themselves, but also of practitioners and experts in various constituencies. And I think there's a huge opportunity to leverage that knowledge that in a way that makes it transferable and also can transform it into a public good. So some of the work we've done in gender as well has really been trying to document some of the knowledge from experts in a way that can be shared and it can be built on. And in terms of the knowledge of the community and people, you know, we tend to see the community and, you know, we see communities and people as users of health services, as beneficiaries, the engagement we do in global health tends to be about using communities to ensure uptake of services or to deliver services. When new interventions come up, global health researchers come in, do formative research, gather inputs from community members, and then they are the ones who are supposedly transforming that data into knowledge, whereas the knowledge of the people that, you know, that is created from their lived experiences and their observations is often not valued as such. And so I think there's incredible opportunity for more effective health programs if we would value that appropriately. And one last point I wanted to make around decolonizing global health. You know, completely agree with Shay that we need to rethink the system. It needs an entire systemic overhaul that rebalances power and explicitly addresses systems of oppression. And we've tended, it's going to be uncomfortable and it will be threatening for some, but it really is a conversation we must, you know, we cannot shy away from. And we have to move away from rushed solutions that are short-term and try to fix the individuals with mentoring or capacity building, but really deal with the system and that oppresses individuals and really try to address the incentives that sustain that system. So I'll stop there. Thank you.
Yeah, thank you. It's really fundamental, the changes that need to be made, and very deep. Our next speaker is Professor Lisa Jackson-Pulver. Professor Pulver currently holds the position of Deputy Vice Chancellor, Indigenous Strategy and Services at the University of Sydney. A visionary educator, Lisa has a deep understanding of Indigenous issues and inclusion, and this is at the heart of all she achieves. She's well known to us all and well loved by us all, and we have a special connection because she actually has been to my hometown of 20,000 people, which is incredible. It's both a global and very local. Lisa.
Thank you so much. And my husband comes from your hometown, only 20 kilometres or 20 miles down the road. So you guys are neighbours, which is fantastic. I paid respects earlier on to the peoples of the land, and I pay respects to all of you. And I was delighted to hear Ms. Clark speaking about how it is Māori recognise land and country in their way. And frankly, it's no different around the world. All First Nations people, all peoples of the land, particularly those of us in, you know, the so-called fourth world, they are the persons who have been colonised primarily by Europeans over the years, all have got a very, very strong connection to country, a very, very strong connection to language and culture. And many of these things, of course, were forcibly removed from them, whether it was from people being dispossessed of their land, whether it was from people being banned from being able to speak their own languages, whether it was people being eradicated from the land, which of course has got a very common story across many places, but certainly here in Australia, where the population went from anywhere between 750,000 people in 1788 to about 1.5 million people, way down to 50,000 people at the beginning of the 20th century. So genocide is a real story. It's very much a part of the ongoing memory of many people. And there are people that I know who talk about how their grandparents would speak about seeing the raiders coming onto country to either steal the children or to do significant harm to those who are there. Today we're talking about health. Today we're talking about the importance of recognising how it is we can learn from each other and share some of the amazing things that we do. I'd like to share a little bit about how we look at health here in Australia, and we recognise that for most of us, health is not just about being physically well. We know that we are healthy and strong when we walk out our front door and we see that others are healthy and strong, that people are not begging in the streets, that people do have somewhere to go, that people are able to have some sort of proficiency over where they move and how they are. And of course, this time of COVID has just highlighted just how serious the inequities are, even in our modern societies. Here in Australia, we're one of the wealthiest nations in the world, yet we still have a profound degree of people who do not have homes that they can go to. who do not have an income that is able to sustain a dignified life, and who, if you're First Nations, have got a burden of illness and disease which is comparable to few other First World nations. So we do have a story to share. For us, Aboriginal health is not only about the physical well-being, but it's also about social well-being, emotional well-being and cultural well-being of not only ourselves, but of our family, of our community and those that we are with. And with each of those things, that individuals are able to achieve their full potential as people and thereby bringing about the total well-being of their community. And I think if you were to think about that carefully, you would probably say, well, that's the same for me. I know I'm strong and well when my mental health is good. I am strong and well when I'm confident that my kids are safe. I'm strong and well when I can open up my refrigerator and serve food to those who visit. I'm strong and well when I know I can lend or receive cash when I need it. And so when we look at how we engage with the world, and we were hearing earlier on in this seminar how it is so many vaccines that could have gone into the arms of people who most need them had to be destroyed because they became up to a use-by date, makes me profoundly sad that as a nation and as a world, COVID affects everybody. It doesn't stand at a border and wait for pass to enter. It comes across, and again, that broadening of inequities is profound. And certainly in Aboriginal communities and Torres Strait Islander communities right now, we're dealing with a devastation that is only becoming apparent to some currently, that the lack of foresight into the needs of people in communities to be able to have bespoke, culturally competent care to get those needles in people's arms to afford them protection is very, very worrying indeed. I also wanted to share a little bit about how we see engagement and what the principles of engagement seem to be on a worldwide way for First Nations people, and I think for most people around the world. When we're engaging in the area of public health, integrity is assessed by how you engage with people, how you do what you say you're going to do and follow through with that, how you have mutual respect and trust, how transparency is important so that you know what it is that people are there for and that there isn't a hidden agenda. That people are engaged and included in conversations, particularly conversations and decisions that are made about them. That is not okay to do things for people. It's only okay to do things with people. And in some circumstances, we certainly do enjoy having Aboriginal people doing the work and making the decisions with community, on behalf of community and for community. And this is something that doesn't happen as often as it should. Things like having active listening skills, learning and talking, and being able to understand another person's perspective, no matter how different it is. It's one thing to say, well, people are just choosing to be vaccine hesitant in some communities, when in actual fact, the truth is that people haven't been able to have a quick discussion with somebody about why it's really important, why these vaccines are important to get into their arms, and the need to be able to look after the young and old equally. Things like respect, being able to ensure that people have a cultural security when they do need to go to hospital or receive care. That much of that provision of service is done by people who are like them, who look like them, who sound like them, who have similar backgrounds, are able to speak the language, whether that language is an Aboriginal English language in certainly our contexts, or a traditional language of country. It is critically important that the respect of cultural rights and cultural needs are tantamount to anything that we do. And finally, of course, community control. In Australia, like many places in the world, there are very strong, large community organisations that know what their communities need, much, much better than a bunch of bureaucrats that might be lurking in Canberra. At the end of the day, people come from country, they belong to country, they live in country, they care for country, and they know how country needs to care for them, and how they need to care for country. In other words, people generally know what's best for them, and it's time we all started to listen. I'll leave it there for now. Thank you.
That's a very strong way to leave it, Lisa. Thank you very much. And our final panelist is Dr. Sandro Di Maio. Sandro is a globally renowned public health expert and advocate, as well as being a medical doctor, and he has a passion for food, health, and well-being. He is the current CEO of Vic Health and has an extensive background, including being the medical officer for non-communicable conditions and nutrition within the Department of Nutrition for the Health and Development at the World Health Organization, as well as being the CEO of the EAT Foundation, the science-based global platform for food systems and transformation. Sandro?
Thanks very much, Nancy. It's a real pleasure to be able to join. It's always a blessing and a curse to go last, but it means I can summarise in some ways. I'll just start by acknowledging, of course, the traditional owners of the land that I'm on here in metropolitan Melbourne, the Wurundjeri people, the Kulin Nation, and their elders past, present and emerging, and acknowledge this always was and always will be Aboriginal land. Well, I mean, when we try to summarise sort of some of the key learnings of not only today's session, but also the wider pandemic, I think, many of the key takeaways have already been mentioned. But for me, really, it's been one of contrast, one of inequality, and one of great opportunity, but also deep concern. The strengths and necessities of a true globalised and interconnected world have never been clearer. The importance of strong multilateralism and a well-resourced United Nations with the ability to be able to protect and serve in a way that's unbiased, evidence-based and future-looking. The cooperation or lack of cooperation that we've talked about already today, and the deep failures that we've seen in these multilateral and bilateral and international partnerships and systems, the almost reversion to old ways, and I think a realisation that a decolonised world is still a long, long way away. And the connections, what we've seen is the importance of connecting at that global level, realising we are, in fact, one planet, that the things that we do in one part of the world have a direct consequence and bearing on populations, lives, livelihoods and futures in other parts of the world, but also on future generations. While that has been clear to us and to many of us for a long, long time on issues like climate or inequality or hunger, those issues are slower motion. They're easier to ignore and often papered over, whereas the pandemic has been unavoidable. At the same time, though, the incredible strength and importance of place-based, our previous speakers have spoken so strongly. And I really do, want to acknowledge, I think, the importance of local community knowledge, of community agency, of lived experience. We saw here in Victoria, as we've seen in many jurisdictions around the world, a top-down centralised approach does not work. Local communities know what they want, know what they need, and often are willing, ready, and raring to get on and solve the issues. But what they need is access, resources, agency, and then often for bureaucrats like myself to give them the platform, the backing, and get out of the way and let them do what they do well. And that's certainly been clear in NCD's chronic disease prevention for many decades, but I think that became incredibly clear through the pandemic. And while we thought about the pandemic in the early stages, there were hopes that it would be the great leveler. Would we have another post-war generation? Would it break down inequalities that were deepening and tearing parts of societies or creating deep rifts between societies around the world? Really, I think the pandemic has either exposed itself as the great accelerator, accelerating many of the incredibly challenging and deeply concerning trajectories the global and regional and national societies were on, or as Helen said, pandemic of inequality. And not just a pandemic, but a pandemic on pandemics. You know, we've had a global pandemic of chronic disease for decades. Margaret Chan described it as the pandemic of slow motion. But, you know, this was a pandemic that exposed our inability to act on the multiple and layering of pre-existing pandemics of malnutrition, inequality, poverty, and NCDs. And what I think has become so clear through the pandemic in particular has been the concept of the social determinants, something that was kind of almost passé, nebulous, a bit esoteric, hard to kind of, you know, get your fingers around. But it truly went from being politically inconvenient to being totally politically unavoidable during the pandemic. And these deep cracks of inequality that we have long papered over in society, within and between and across societies globally, were exposed for what they were. You know, they became the Achilles heel of pandemic response, just as they have been the major drivers of other pandemics for decades. Again, inequality, poverty, NCDs, things like, you know, poor quality housing or poor access to secure and safe and high quality housing, or secure employment, being able to take a day off and actually have access to respectable leave entitlements or job security, or high levels of health literacy, or trust in government and science, or even, you know, really basic things that we should have long gotten right, like respect, dignity, and agency, regardless of who you are, where you come from, your postcode, or your income. But more than that, we've seen how the political, economic, social, and commercial barriers are alive and well that stand in the way of communities achieving and maintaining good health. And I had a young person put it so eloquently as they paraphrased recently at a Vic Health event. You know, we might all be in the same stormy and choppy ocean, but we're not all in the same boat. Some of us are in a rickety canoe and others are sailing through in a pretty nice yacht. And then we've seen, of course, the layering of this disadvantage, you know, in the intersectionality of disadvantage. So for me, the pandemic has really highlighted the strengths and opportunities of globalism, the importance of global cooperation, the idea that what we do in one place is, of course, going to have a bearing and interdependent, and also that we have a global responsibility. We've set these targets while we've failed to act, and we're further from our SDGs today than many of them than we were 5-6 years ago when we set them. We do have that global responsibility. But at the same time, the strengths, the innovation, the insights, and the solutions ultimately lay at the local level. And so that's really been the insight that we're building our strategy on here at Vic Health. Local place-based models with and not for communities, but at the same time strengthening our commitments to global alliances, global interdependencies and cooperations. And so as we look forward, I think really the things we need to have in our minds are, you know, how do we build back not just better, it needs to be more granular than that. We can't return to a 2019 world where 2 in 3 Australians were suffering from chronic disease, or, you know, the leading causes of death were preventable, if not significantly delayable, everywhere in the world, or 2 in 3 people across the planet are malnourished and 1 in 5 children are stunted. We need to aim for better. We need to build back fairer and healthier and aim for a baseline health going into the future, which is higher than we left 2019. Not only because it's the right thing to do, and it's going to benefit everyone, but also because we know other major shocks are coming, far bigger shocks are coming to the global system than COVID has been. This really is the canary in the mine. And so now is the time to prepare. Finally, I'd just say we need to also embrace this window of policy opportunity, the opportunity to build well-being into our economies and into the business of government as a core tenure across all parts of government. And if not now, you know, then when, and if not, you know, who then, and if not us, then who?
Indeed. Well, let's start with an easy question. So, Shea, how do we create a knowledge infrastructure for global health that actually meets the needs of middle and low income countries? You know, what would that look like? You talked about that, but what would that look like? What does your imagination kind of tell you that we could achieve?
Thank you. So I can try and sort of relay my imagination in a few spaces in which knowledge, knowledge-rich spaces. One of them is how we train people who do public health and global health. The kinds of knowledge, the kinds of perspectives that we privilege, how we, for example, train people to begin from the local, to begin from the knowledge that is held within the spaces where they work, how we train people to focus on the local interpretations that they find where they go, how we train people to focus on what is structural, as much as they focus on what is downstream, how we train people to respect other people, and especially in an Australian context, how we think about Indigenous health and equity in the same way, or parallel, or in a similar context and space as we think about global health and equity. Because for me, one of the things that we miss when we train global health and public health people in Australia, I think, is to imagine that there's a substantial fundamental difference between what we're doing in that space and what we may want to do in Indigenous health and equity space. Because I think a lot of cross-learning between those two spaces would help a lot in how we will think about what happens in LMICs. The second space, perhaps, is the space of academic publishing. So when you imagine what, for example, a standard paper looks like, Michelle mentioned earlier that academia or research in global health is optimized for the biomedical. So for example, when you think then about what the structure of a research paper looks like, sort of introduction methods, there's a whole sort of thing going on there. And in the introduction, you, for example, want to make the claim that you are the first to say something, the first to find something. You make a claim that, you know, there's the knowledge gap, that no one knows this, and I'm going to answer your questions for you. And you can imagine a different practice in which, for example, conducting a study in a particular location, you begin from what people there already know, what they were doing, what their learning needs are, why you are the right person to help them fulfill their learning needs. Right? And then you, for example, move to the method segment where you start to then talk about how you collaboratively, collectively came up with the right question and the right method to answer it. And then perhaps in your findings, you describe what you found, mostly in terms of what you learned and what they learned and what they might learn. And in the discussion section, you want to perhaps talk about how that learning was fed back into the system, help to connect the system to more of itself, and perhaps what others may learn from that process. Now, what I just described is quite different from how we imagine what a research paper is and does. So that's another example of how we might imagine a different future for a global health knowledge infrastructure that serves people and begins from what people know and respect what they know and help them to learn from themselves, about themselves, and for themselves.
Yeah, and to pick up on this, Michelle, when we talked, you talked about how policy and program people actually can be more open to different types of knowledge than your typical scientist or health practitioner may be, and how they sometimes can create space for the knowledge held by practitioners. Would you be able to talk a little bit about that and talk about how we might be able to expand on this or learn from these types of practices to improve and our globalization of knowledge and leadership?
Sure, thanks. Yes, I think one of the things I would say, Shay was talking about starting from the local. And I think we also need to be starting from a place of co-creation of knowledge as a matter of values, but also as a matter of, being effective, equitable, and having impact. And I think the violence against women field provides a rich example of actually of that kind of co-creation. And I'm going to be drawing on an analysis by Jessica Horn, and it's been published as part of our Gender and Health Hub Think Piece series. So just to give due credit. But in violence against women, civil society has played a critical role in building knowledge on the prevention of violence, in raising awareness, public attention to the issue, and also getting it on the global health agenda and ensuring there was accountability. But specifically, the feminist civil society actors collaborated with public health researchers to get this issue to be seen as more than a social and legal issue, but also a global health priority. And the feminist civil society actors were really vital sources of innovation in developing the intervention models based on their knowledge of the context, their engagements with communities, and really responses that were advancing both health outcomes as well as social outcomes, which are not often, tend to be undervalued, I think, in biomedical frameworks. And what I thought was really interesting in that, and this is of course over decades, but it's been really interesting there to see is that they grounded the work of violence prevention in ecological frameworks, in feminist ethics, and in power analysis. And they made sure there were commitments to accountability to women and girls, to centering experimentation, and to recognizing practice-based knowledge. And they were operating in a space with, a public health discourse around risk factors and drivers and quantitative frameworks, but they were able to assert the validity of feminist and experiential language and analyses alongside those ways of thinking. And some examples that Jessica highlights are the use of popular education methodologies when speaking about interpersonal power or exploring emotional impact of violence in family and community, as well as the passions that help to change this. And so it's just a successful case, I think, of where activists and practitioners in this space have been recognized as co-producers of knowledge and what that can mean for innovation and impact. But of course, they've also had challenges, and like other areas, they're still confronted with existing knowledge hierarchies and feminist civil society and global South communities being seen as objects of study, whereas the global North constituencies are the producers of knowledge. But I think it provides there are some really good examples there to imagine how practitioners in these local settings and from civil society organizations can collaborate and work with researchers to generate knowledge too. But they need the resources to do that. And I think it's been really challenging to see that they still have to negotiate and convince funders that they're more than program implementers, that they are also generating knowledge and that they need the resources for that reflection and that consolidation. And I think if we don't, I think that's a great example. And I think if we don't get that right more going forward, we're going to be missing opportunities to really build stronger and more adaptive health programs and knowledge systems. And if you will allow me just one quick thing about more around the decolonization agenda, I think one really critical part, and it links to this co-creation piece, I think we also need to co-create accountability systems, and we need to, at UNU, we really believe it's critical to shift whose voices are shaping this conversation. And if you look at, just the discourse in academia and the publications, my colleague Emma Rule has done a review of this, and she's found that only 2% of papers on these issues are from institutions, people, authors and institutions in the global South. And so we really need to make sure we're going past and not falling into this savior narrative and making sure that these voices are the ones shaping what success looks like. They're critical to that these people are at the table, they're shaping the structures and defining how we hold ourselves accountable to change.
So I think that we could talk about that for, I think, hours. But it's so interesting when we're talking about knowledge and how we construct knowledge. And Lisa, when we talked to you, you talked about how we have this Western construct and we try and kind of pigeonhole or try and just kind of add stuff, indigenous health knowledge, indigenous practices and knowledges into that. And that really, it doesn't work. And so what do you see as kind of a new approach to trying to not try and kind of fit indigenous health and knowledges into this Western construct, to develop something different, something better?
Okay, so I'll start with something that might surprise a few of you. Evidence-based medicine is not. Okay, so a lot of the medicine that we teach people is based on practice and what people have been doing for a long, long time. And when you start discombobulating it and teasing out why people do certain things or prescribe certain medicines or do particular procedures, it's not necessarily based on the epidemiological evidence, but it's based on this is the right thing to do because this is what we do. When we look at Aboriginal knowledges, and I'm sure this is the same for other First Nations around the world, there is a very, very strong and persistent pharmacopoeia, a very, very strong knowledge base of how it is people have done stuff for a long, long time to keep themselves fit and well and strong and not dying. I remember once in my very early medical school days, someone said, isn't it great that we came here and saved all the Aborigines from having syphilis and dying of smallpox and, you know, and I was just gobsmacked. I didn't know what to say. I thought, this is serious. You've got to be kidding. This is a really bright kid that came through matriculation to get one of these coveted places in a medical school and would come out with something like that. Made me recognise we have a long, long way to go. So firstly, I think we need to redesign the conversation. And this is very much an Australian perspective. So firstly, I would love to recognise that Australia is actually in the physical south. It might be part of the north economically and geopolitically, but it's absolutely not when you start looking at the health of her First Nations people and the sorts of things that we have. We have got flagrant rheumatic heart disease in some parts of our lands. You know, this is 100% vaccine presentable disease, right? We have got health outcomes for mums and bubs that are profoundly poor. So if we start the conversation from firstly recognising that Aboriginal Australia has got a very, very strong and lasting pharmacopoeia and that there have been practices that have been engaged for a long, long time that kept people strong and well, and recognise and elevate that knowledge, that would be a good start. Secondly, to recognise that a lot of stuff that is really good for Aboriginal people is really good for everybody else. So if we look at primary healthcare, for example, it was Aboriginal communities that commenced the whole proposition of primary healthcare. And now, when we look at care being rolled out across Australia and across the world, you see primary healthcare is the stoppers of the profound problems that do not need an ambulance at the bottom of the cliff. You know, so this is all the nice, lovely intervention-based stuff. This is all about the health promotion stuff. This is all about the education stuff. This is really what makes a difference when people have got control of their own health concerns. They don't go on to get the really bad diseases that require really expensive pharmaceuticals, surgery, or other interventions. So if we can recognise that. And then the third thing, of course, is very much around, if you get it right for Aboriginal people, there's a good chance you'll get it right for every other sector in society. So if you set up a system that looks after the needs, the cultural needs, the physical needs, the emotional needs, the spiritual needs, you will have a system that is able to embrace the utter great diversity that is available in this land. In Australia, I know people recognise that at least 1/3 of our population was either not born here or had one of their parents born overseas. Over 40% of people in the large urban centres speak a language other than English at home. This says Australia is hugely diverse. It's a hugely different place to what it was at the turn of the century to what it was at the turn of the 20th century as well. And so if we can consistently and persistently maintain a system that is very, very old, you know, the hospital-based system and the health system is something that is way, way back in the early 1900s, the 1920s and the 1930s. If we don't take a big, deep breath and say, if we were to build a brand new system from scratch today, what would it look like? I would be, and I'm not a betting woman, I would suggest it would be vastly different to the one we have today that we persistently and constantly have to retrofit. So I think it's up to all of us to say, stop. Let's really look at the evidence. Let's really look at what works for people. Let's listen to the voices of the people who utilise our services. And we are those as well, all of us here, we are those as well. And get some common sense into it. Look at public health measures as a good, strong, preventative, intervention-based approach, and then I think we're going to end up with a much happier and healthier population, and certainly do justice to this land that many of us call home, that has given us sanctuary and safety for such a long time. It's time to pay respects and it's time to pay the rent, and that's one way of doing it.
So we just have a few more minutes, Sandro. So maybe just let's talk a little bit about how we think of health, how we think of the health system, but how we think of, you know, instead of, you know, as Michelle was saying, you know, focusing on, you know, the biomedical in terms of what is evidence and the focus on the health of the individual. How do we start that bottom up versus top down? And how do we focus on health of communities? And how do we ensure that we have healthier communities in Australia and globally when we're thinking of global health?
Well, I think Nancy's already started, and I think a lot of it really has been covered. I mean, you know, it's about those of us in positions of power, you know, stopping, reflecting, listening, and ultimately looking for ways to hand over power. It's about acknowledging that most of the solutions do lie at the community level, within communities. That communities, while they might face structural, social, political, cultural barriers and disadvantage, they're not vulnerable. There's a huge amount of strength in many of the communities we've talked about today that, you know, Todd and Lisa and Say and Michelle have talked about, and Helen. So I think that movement has already started. I do think the pandemic has made it crystal clear. There are, you know, with privilege, you know, when we're talking about challenging privilege and decolonizing and looking at where power and privilege, shifting of power and privilege, you know, that will inherently make certain individuals, certain societies uncomfortable, because, you know, there is going to have to be a handing over of power and a redistribution of power. You know, but I think, again, I think it's already started, and the opportunity of the pandemic, the fact that health is front of mind, the fact that these issues, structural and social, commercial, political, cultural barriers have become so crystal clear, and that we have an infrastructure and a spending and a political will, regardless of politics in many countries, to act on some of these. You know, I think there is a kind of a perfect opportunity to accelerate, you know, this transition of power and a deeper reflection on the role and practice and where power and privilege lie in the global health system.
Well, we have one more question, one last request, and Shea, is it the second question that you wanted to address, or the first one?
Second one.
Yes. So we have a question from the audience that one of our panelists is really wants to address, and if we had had hours, we would have had an extraordinary conversation that no one would have found dull, but we are very constrained for time. But one final question: given external pressures to publish in peer-reviewed journals, is it possible to redress the imbalance in global health evidence within this system, and what alternatives might there be?
Thank you. The reason why I really wanted to answer this question is that I think it goes to the heart of a lot of what we've talked about today. That this system, however we define it, is made up of people, and those people include us. So every time we say the pressures are external, it is this system, I think we allow ourselves to imagine that we are not part of it. So I think that, you know, the amount of collective action that it will take to do an alternative system, I suspect, will be much less than it would take us to actually reform the ones that we're a part of. That if we could come together and reason together and agree that something is broken about this system that allows us or makes us do stupid things, then we can also say, hey, system of which I'm a part, here is what I need to do the right things. And of course, again, as Michelle said, it's going to be uncomfortable because people's power and comfort will be threatened and shaken, but we have no alternative. Right? If we want to do the right things, we are going to have to ask and make difficult demands and change ourselves, because it's not just the system. Again, we are not outside of the system. We are part of it. We all subscribe to it. We all prop it up. So we can also change it.
It's a wonderful way to end. We can change it, and if the system isn't actually really benefiting the globe in terms of improving health, you know, it's time to change. And I agree with you and also with Lisa about, you know, it taking much more effort to actually reform a broken system than to redevelop something and do it in an ideal fashion. So again, we could talk forever. Thank you so much to the panelists. It was wonderful to learn about you and your passions. And I just wish we had more time, but we do not. So back to Selena.
Thank you so much, Nancy, and indeed the panel for such an engaging but important conversation. So just to announce that we will go for 10 minutes more, and I am pleased to commence the last but in no means least session for today, and I hope many of you can stay, Through the generosity of the Global Health Film Festival Archive and the festival director, Jerry McHugh, who is studiously calling in from Northern Ireland in the audience right now, we have a special film screening to share of global health. I welcome Professor Susan Sawyer to the Zoom stage to introduce both the film and its director. Susan holds the Jeff and Helen Hanbury Chair of Adolescent Health at the University of Melbourne and is Director, Centre for Adolescent Health at the Royal Children's Hospital, a WHO collaborating centre. She's a paediatrician and her efforts have truly helped to expand global understanding of the importance of adolescents and their health and wellbeing in Australia, but globally too. Susan is president of the International Association for Adolescent Health, and she's held numerous advisory roles for WHO and is the inaugural co-chair of an Australian network of WHO collaborating centres. We're indebted to Susan for all her work and for today agreeing to be with us. Over to you, Susan.
Thank you, Selena, and I'd also like to acknowledge the original owners of our land. I'm speaking to you from the Wurundjeri land in Melbourne and really wish to celebrate and acknowledge the depth of their knowledge, connections and custodianship of this land. And Selena, I'd also like to echo Brendan's recognition of your appointment by saying how pleased the Australian Network of Collaborating Centres is that you are leading the Australian Global Health Alliance, so keep it up. But for this final section, I'm really delighted to have the honour of introducing Helen Khan, who's joining us today or this evening from California. Helen is one of the two directors of A Quiet Inquisition, the short film we are about to watch, which was initially screened as part of the Global Health Film Festival. She's been collaboratively producing documentaries with Alessandra Secca since 1998 on a wide range of issues in an equally wide range of countries, including Albania, Rwanda, India, Taiwan, Central America, as in the case of this film, and the US, supported by the Sundance Documentary Fund, the New York Foundation for the Arts, among others. A Quiet Inquisition tells the story of a Nicaraguan public hospital obstetrician gynecologist as she contends across her days with the harrowing implications of a new law that prevents the termination of any pregnancy, even when a woman's life is at stake. And I must say, I did find this an extraordinary film. Helen, we would be delighted if you could share a few words about the context of the film, which as an advocate for adolescent health, I confess to finding very powerful in its seemingly simple telling of a number of very deeply challenging issues. Over to you.
Oh, thank you, Susan, and thank you, Selena, and everybody at the Global Health Congress. It's really great to be here. I'm speaking to you from Chumash land in what is now called California. And I know we just have a few minutes, so I'll try to give some context. I do want to thank also Global Health Film and Jerry McHugh, because this film wouldn't be here without them. They've championed it since their inaugural festival in 2015. And sort of central to Global Health Film is storytelling and the way in which storytelling opens up the issues of global health around the world and kind of brings them, sort of brings the layers alive. And I think that that kind of storytelling is really central to the context in which A Quiet Inquisition emerged. So, how do you take a really sort of what is, referred to as like a hot button issue, right? Abortion that so divides people, that so kind of gets reduced and spoken about within a certain set of languages and a ways of sort of already polemical understandings. And when Nicaragua about 12, 13 years ago changed their laws, laws that had been in action for 130 years, sort of since the Nicaragua had become an independent nation, abortion to some extent, the termination of a pregnancy was protected. And suddenly all of those laws were being overturned. And as Susan said, the criminalization of any termination of a pregnancy. So it was into that context that Alessandra and I sort of entered, really wanting to make a film in collaboration with the community of people who were being sort of impacted by specifically the way in which fear functioned within this law. So, so we wanted to make a film sort of that focused on the day-to-day impacts of the law and kind of on the ground within a general hospital setting. It was interesting in the panel before, which was so interesting. I could have listened to the entire evening. Michelle talked about sort of the co-production of knowledge, right? And Dr. Carlos Sorato, who is the central figure in the film, really became kind of a collaborator in letting us into the intimacy of the rooms within the hospital, but also into the kind of a really holistic understanding of the confluences of events that got us to the set of laws. And sorry, it's a little hard to kind of get all of this in a few minutes. I'm all over the place. But so it's the story of kind of how is a doctor and her colleagues sort of navigating the day-to-day impacts of what is not necessarily being prosecuted yet, right? It's sort of the initial sort of onset of a law, and sort of how does that fear function, and how do they find their own autonomy or agency within that, and that relationship between the impact of the of choosing between the sort of medical protocols that you know, right, versus the state, the hand of the state, right? So that's kind of the central figure. And we saw this as a harbinger of what was happening, not only in Nicaragua, but what is happening across the globe. It's happening in the US, it's happening in Poland, it's happening in many countries that had protections. And now, even under liberal governments, are sort of being rolled back, right? And so to find something that, to find a kind of way in that was intimate and nuanced and complex, and could kind of look at the impact on the lives of women and girls and the doctors, workers, and the sort of fabric of society was sort of what the aims or the context of the film was. So sort of that's the kind of in a nutshell. Sorry, I've never tried to do this in a few minutes.
No, you've done it beautifully, but I think we the way to really experience that, having seen it, is that when people see it, they will absolutely appreciate your words, I think, even more. So thank you so much.
Thank you
to Abby for starting the film. Thanks.
Una niña de 22 años trasladada prematura membrana con un embarazo de 17 semanas. Se le hizo todavía un ultrasonido en donde se reporta que el producto está vivo. Y el médico en ese momento puso producto vivo en espera que fallezca para poder inducirlo. Ya en la tarde ya había iniciado el shock séptico. La mamá se pregunta, ¿pero por qué no hacen algo con mi hija? Porque hay una ley, señora, ¿y si se me muere? Bueno, usted puede ir al gobierno, preguntarles a ellos, ¿por qué se me murió mi hija? Y muere allá a medianoche. Tú vas a vivir con eso. Por cumplir una ley no cumpliste una norma. ahora no tenés mucho dolor acá. Aquí en emergencia no. No sabes quién es la que está grave, quién es la que está mal. Vienen llenas de ansiedad, de miedo. A veces pueden exagerar los dolores, pero a veces no, a veces todo lo contrario. A veces vienen calmaditas, serenas y ya están listas por parir, ¿verdad? Adiós, que te vaya bien. Todo pasa, ¿oíste? Cosas buenas y cosas malas pasan. ¿Estás lista, de veras? Ella es Tuyen, una niña de 13 años. El diagnóstico con que le envían es en trabajo de parto con preeclampsia grave. Preeclampsia grave es cuando tenés la presión alta, ¿verdad? Con embarazo. Muy frecuente en adolescentes. Bueno, ¿como cuántas, Fátima? De 13 años, tal vez en el mes unas 7. Sí, más o menos. Bueno, mira, el grupo de los adolescentes, lógicamente, tenés que dividirlo en 3. En menores de 14 años, entre 14 y 16, y más de 16. ¿Ya? Entonces, porque el riesgo, lógicamente, es mayor entre menos años tenga, como ella. Preferiblemente el parto. En el parto va a perder menos sangre. En el parto va a estar su esposo. Si fuera una cesárea, el esposo no puede estar con ella. Entonces pensamos que el acompañamiento del esposo siempre son buenas noticias para la paciente y para el bebé.
¿No lo planeaste? ¿Cómo fue eso?
Yo le dije que podía ser que saliera embarazada, pero ella me dijo que no le importaba, que no era rico, que lo querían, pero dinero.
¿Y qué años tiene ella?
30 años.
¿Y vos?
24.
Vamos a llevarla. No te vamos a hacer los detalles, pero te voy a dar un poco de sangre. ¿Ok? ¿Lo hiciste bien? ¿Ahorita lo hiciste? Perfecto. ¿Por qué no ahora? Lo importante en esto realmente es la vigilancia estrecha, y más ahorita en el expulsivo. No te despegues de una chavala así, no te despegues. A cada rato, cada 5 minutos el foco, corazoncito del bebé, ¿ya? Animarla. Pero tiene 9 a 10 centímetros, ya está metidito. Si serán 60 pacientes en un turno de 7 de la mañana a 3 de la tarde, yo miro 30. Y supervisar los ingresos de ellos 3. Entonces dice Tuviste un bebé hace 2 años, a los 16, hiciste tu segundo. ¿Fue cesárea? La mayoría de las que yo veo son en adolescentes. Y la otra parte de la agenda, si vos has visto, es de planificación familiar. Entonces por eso ves una parte que son adultas y la otra parte son adolescentes embarazadas. Vos tenés una prueba de embarazo en orina que me contaste que había sido positiva hace como un mes, tu mamá o algo así te dijo, ¿no? Por eso esa salió positivo. No, esta es otra, vamos a ver cómo sale. Uh-huh. ¿Y entonces ya tienes un bebé o...? Un aborto. Tiene un embarazo. Este es su segundo embarazo. Entonces, el primero fue a los 13 años. ¿Cuándo fue? Entonces ahí nomás te quedaste de nuevo. Febrero del año pasado. Ah, pues no, hace poco, mi reina. ¿Mm? Por eso de 13. Bueno, ¿estás preocupada? ¿De que te salga positivo o de que salga negativo? ¿Cómo? ¿Ah? Positivo. ¿Estás preocupada por si te sale positivo? Va a salir negativo. A ver. Venían rogando para que fueran negativos. Eso ya está en un minuto, ¿viste? Voy a ir a traer a la camioneta unas cosas que tengo. No se aflija, hombre. ¿Ah? Tierna está.
Yo por lo menos ahorita que estoy esperando el resultado de mi hija, un ultrasonido transvaginal ya más va a definirnos si la membrana está picada o no. Viene toda perforada la membrana, el niño ya no tiene esperanza. Entonces ella quiere apegarse a la vida, ¿verdad? Si nos dicen que todavía con tratamiento y todo, pues cuidamos, siempre en Dios cuidémosla, démosle lo que le vamos a dar, y si hasta que el niño tenga vida y todo, pero si ya comienzan infecciones, otras complicaciones que hasta sin matriz se va a quedar, y una chavala de 28 años, yo digo que mejor actuarlo más antes. Y siendo cristiana pues, pero no me divide esto de lo otro. En mi opinión, si doctor proceda, mi hija, al ver que ya no se va a reponer, que ya bajó, que va a estar haciendo un pececito sin agua en una pecera, entonces, pero no sabía, porque vamos a esperar que hasta se puede infestar y después me le van a sacar la matriz entonces por último.
Pero quiero que esté clara que no es una decisión del médico.
No sabía, y antes nos decían, firme aquí, y uno firmaba, pues, y ya se procedía.
Ah, en ese tiempo estaba aprobado el aborto terapéutico.
Está propensa a una infección, una matriz.
Pero yo le voy a aclarar eso. Aquí no le vamos a inducir el aborto.
No sabía yo que, por ejemplo, si ahorita viene el diagnóstico que dice que está toda perforada la membrana, la membrana, pues, y que el líquido amniótico no se va a reponer y que está ahí, y que vamos a esperar, pues, que el niño. Entonces yo estoy arriesgando también a mi hija. Claro, en este momento a mí me dicen su hija o su bebé. Yo creo que lloramos por los dos, pero siempre decimos mi hija. Presérvenme de la vida a mi hija.
So very much big thank you, Helen, for being with us today to share your beautiful film. Thank you indeed. And thank you to Susan, who has just left the Congress. So I'm going to close the Congress, but before I do, I just want to say a few words of immense thank you to Nancy, Cher, Michelle, Lisa, Sanjo, Brendan, Helen, Todd, Jacqueline, Nat, and all friends, members, founders, and executive advisory committee members of the Alliance for making today special and giving us your time and trust. Special shout to Abby Piali and our interns at the Secretariat. I hope you join us for more events in the next year as we look forward to the launch of new initiatives, including a collaboration with the Alliance and the Global Health Film Festival, and other collaborations with current and new members and between members. We have a responsibility as a global health community to look out for each other and our place, whether it's be in the global health milieu overseas or in our locale. We hope that these conversations reflect our commitment to you and the future of global health in Australia overall. So stay safe and well in all your locations, and we look forward to working with and hearing from you in the year ahead. From me, it's goodbye from Wurundjeri land, our home in Melbourne, Australia. Thank you. Goodbye.